It's my pleasure to welcome my longtime colleague, Dr. Wendy Spearman, who's head of the Division of Hepatology in the Department of Medicine, Faculty of Health Sciences, University of Cape Town in South Africa, to explore these guidelines in more detail and what they mean for her own practice setting. Wendy.
And thanks, John and team, for really asking me to give impact of these guidelines on the low-income countries, which really is quite close to my heart. Let's just get that up. I'm going to really give you some insights into the impact of these guidelines in low and middle income countries. So despite diagnostics, preventative vaccines, and effective antiviral therapy, as we know, hepatitis B remains this major public health problem. And in 2022, it was estimated about 254 million people were living with hepatitis B, and it accounted for 1.1 million deaths. But as we've heard, only 13% have been diagnosed and less than 3% treated. So globally, we're off track to meet these 2020-30 hepatitis B elimination targets, particularly in low middle income countries, which account for the highest burden of chronic hepatitis B worldwide. And so if we look in Africa, 65 million, in Southeast Asia, 61 million, and in the Western Pacific, 97 million are estimated to be living with hepatitis B. And unfortunately, more than 2/3 of cirrhosis and liver cancer cases related to chronic hepatitis B are observed in these regions. And even more concerning is that most of this global burden of chronic hepatitis B can be attributed to mother-to-child transmission at the time of or shortly after birth, and this leads to high rates of chronicity. And so if we look about those low and middle income countries, we've seen the different regions, the Africa, Southeast Asia, Western Pacific. But if we look at the number of countries, they really are falling within the WHO Africa region. And that's really very concerning if we think about how we're going to address implementation of these guidelines. So in terms of diagnosis and treatment, Africa region, it's estimated there's about 4.2% coverage with only 0.2% treatment coverage. In Southeast Asia, about 2.8% diagnosis and 0.1% treatment coverage. Doing slightly better in Eastern Mediterranean area, which is 14.7% diagnosis and 2% coverage. And Western Pacific has made quite recent strides in actually improving diagnosis up to 25%, with treatment coverage of 6%. But as you can see, falling well short of those 2030 elimination targets. So scaling up testing and treatment towards the 2030 elimination goals will really require a radical simplification of diagnostic approaches, treatment criteria, and service delivery models that needs to address integration if we're going to overcome the barriers in access to hepatitis B testing and treatment. So one of the big barriers is really the cost and availability of diagnostics and this real problem of out-of-pocket expenditure. And so we look here within Africa and the Western Pacific in terms of hepatitis B testing. There's a large proportion which is out of pocket. And then even more concerningly is this wide discrepancy in the cost of the hepatitis B DNA assays. This is data from the CHIA initiative in low middle income countries. And you can see it's as low as $9 US in Rwanda, but Indonesia ranges between $28 and $62. And so we need to overcome these discrepancies in actually costing of what is really an essential monitoring tool for hepatitis B. So in terms of the international guidelines, including the WHO 2015, all these guidelines really incorporate hepatitis B DNA and ALT levels into treatment decisions. And they provide guidance on biopsy or the assessment of fibrosis and recommended treatment indications that varied according to the chronic hepatitis B status and considered other factors such as age, family history of cirrhosis, or liver cancer. And they all agree in terms of the goals of therapy to improve quality of life, survival by preventing progression of disease to cirrhosis, end-stage liver disease, liver cancer, and death. But I think we need to realize the guidelines need to be relevant and implementable in the different regions of the world. So these updated guidelines, as we've seen from John, now provide 4 options for meeting treatment eligibility that will capture at least 50% of all surface antigen positive individuals compared to the previous 8 to 15%. So we now have the new APRI criteria for staging liver fibrosis. Importantly, we have alternative viral regimens that now are promoted. This enables potential access through HIV programs. So if you have access to monotherapy with tenofovir and lamivudine or tenofovir and tracitabine, this can actually now be used to treat. And so the limited access in some countries to tenofovir monotherapy should no longer be problematic. Tenofovir and entecavir still remain those first-line regimens. And then very importantly, this access to antiviral prophylaxis for surface antigen pregnant women. Importantly, if you lack access, as we've heard, to DNA quantification, in fact, if you merely surface antigen positive, you should be offered tenofovir prophylaxis. The use of point-of-care surface antigen rapid diagnostic tests and hepatitis B DNA levels needs to take this testing down to primary and community care level, and the reflex hepatitis D co-infection testing, which I think we'll see might be difficult to implement in some regions. And so we look at these 4 recommendations of who to treat. It's all adults and adolescents over the age of 12, and this includes pregnant women and girls. And I think very importantly is not what one really didn't want to miss was those who had significant fibrosis based on an APRI score or liver fibrosis or cirrhosis, and you could treat regardless of what that DNA or ALT level was. And then importantly, in the absence of a DNA assay, if you had abnormal ALT levels on 2 occasions only, and you were surface antigen positive, you could initiate treatment. And I think what I'm going to go into a little bit more detail, you see there's actually one cutoff for the DNA of greater than 2000. And the ALT really is just, is it above the upper limit of normal to help you make the decision to treat? So this is really a public health approach aimed at national program managers from low middle income countries and their frontline clinicians. And these are often non-specialists, so it's not an individualized approach. The members of the development group really represented the 6 WHO regions, and importantly, 15% were working in low middle income countries, so had insights to the barriers and challenges that we face in implementing complex guidelines. And the aim, as we've heard, was to increase the number of people living with hepatitis B who were diagnosed, linked to, but importantly, also retained in care. So if we look at simplification of care, we need simplified treatment algorithms. So understanding that complex natural history of chronic hepatitis B, with which hepatologists love, they love those different 4 phases. And this is associated with specific virological profiles and different clinical prognosis. But this really was a barrier to initiation of antiviral therapy. It required repeated tests of measurement of the viral load, transaminase, assessment of fibrosis to predict the risk of liver-related complications and provide appropriate monitoring and antiviral therapy indications. And the level of monitoring, particularly the viral load and liver stiffness measured using transelastography, was seldom accessible in routine clinical practice in low-income countries and was mainly out of pocket, as we've seen. So we've seen that modeling studies have really shown that the treatment coverage needs to be increased to up to 80% amongst people eligible for treatment to meet those 2030 elimination targets. But as we've seen, according to the current International Liver Society treatment guidelines and the previous 2015 WHO guidelines, this only less than 20% of people living with hepatitis B were eligible for treatment. And so what we hope is that these new guidelines will have a positive impact on countries that represent 2/3 of that global disease burden, as seen in this table. So looking at diagnosis and monitoring, depending on the clinical setting and the availability of resources, you can diagnose significant fibrosis and cirrhosis based on the APRI score, which really just requires access to ALT and platelets, and you can initiate therapy. The recommended point-of-care surface antigen rapid diagnostic tests are aimed to actually improve diagnosis at primary care level, but also prevent the loss to follow-up. In terms of the hepatitis B DNA testing, the Gene Expert DNA point-of-care tests have excellent diagnostic accuracy. And we need to remember there are almost 7,000 CAFED expert platforms across Africa, mainly used for TB and HIV, but there's extremely good awareness how to use these platforms, and we need to actually increase our use of this, particularly for hepatitis B. Viral load, as we've seen, is no longer a barrier to initiation. If you surface antigen positive and elevated ALT on 2 occasions, that is an indication to start treatment. And what about the lowering of the DNA cutoffs? A single cutoff has been chosen at 2000. This is going to be much easier to implement. A systematic review of 69 studies, mainly from Asia, showed what we know is this dose-response relationship between baseline HBV DNA levels and incidence rates of liver cancer, cirrhosis, and liver-related deaths. And the number needed to treat to prevent 1 case of HCC, you can see, decreases as the DNA level rises above 2,000, so between 2,000 and 20,000, 59 cases, and more than 20,000, 14. And then importantly, the number needed to treat to prevent 1 case of cirrhosis, once again, rises above 2,000, between 2,000 and 20,000, 21 cases, and greater than 20,000, 7 cases. And I think what's really going to also help the implementation is the use of a single elevated ALT if the DNA is greater than 2,000, or if you have no DNA access, an elevated ALT on 2 occasions. Treating advanced fibrosis and cirrhosis, irrespective of the DNA or ALT levels, This is important. Hepatitis B remains a leading cause of cirrhotic deaths in low and middle income countries. And these simplified criteria enable easy implementation of accessible diagnostic tools. This avoidance of the gray and indeterminate zones associated with different ranges of ALT, previously between 1 or 1.5 times normal, or more than 2 times normal, and there's different DNA ranges. Avoidance of these actually will enable the much easier implementation, particularly at primary care level. Lowering of the threshold, the APRI cutoff of 0.9 for significant fibrosis and 1 for cirrhosis, is very relevant for Africa. The previous WHO recommended APRI of more than 2 for cirrhosis. Studies from Ethiopia showed that this missed 50% of individuals eligible for treatment according to the EASL criteria, and 52% of those who fulfilled the WHO criteria already had decompensated cirrhosis. So this new APRI threshold aligns with the HepSNet systematic review and individual patient data meta-analysis, which looked at nearly 3,500 chronic hepatitis B patients from Africa and recognized that an APRI score of 0.65 was the threshold for cirrhosis. And then this important prevention of mother to child. This is a key intervention to accelerate hepatitis B, particularly in low middle income countries. The recommendation is that highly viremic women, if they're e-antigen positive or have a DNA level of greater than 2,000, remains. But this really has been a major barrier to actually implementing mother-to-child prevention strategies. There's access to e-antigen serology and DNA measurement. And so now, as we've heard repeatedly, you can treat if you have no access to the hepatitis B DNA or e-antigen serology. But importantly, this should not take the place of the birth dose vaccine, and we need to improve this. At the moment, there's only 18% of countries within Africa have a timely hepatitis B birth dose vaccine. And pregnant women must be referred for ongoing assessment for the need for long-term tenofovir. And the guidelines also recommend this as an opportunity to screen partners and siblings and children for surface antigen, and thereby vaccinate, treat, and break cycles of infection. And then this vexing issue of the reflex hepatitis D co-infection testing, depending on resources, it's obviously advised that all surface antigen positive individuals are screened. But in reality, I think we're going to be looking in low-income countries at individuals at increased risk of co-infection, particularly in countries such as Mongolia, Moldova, and countries within Western and Central Africa. But what are the implications? I think the cost of the serological and molecular diagnostics will remain a barrier, and particularly the cost and availability of the treatment bulevirtide. And I think this will be very difficult to implement within Africa. So in summary, the new guidelines are a public health approach to the management of hepatitis B, aimed at expanding criteria for the initiation of treatment and promoting implementation in low and middle income countries. I think it does help to demystify the management of hepatitis B. Initiation of tenofovir no longer dependent on understanding this complex natural history of hepatitis B with the 4 phases of infection. Access to DNA is no longer a barrier to treatment initiation. And promoting point-of-care diagnostics, the rapid diagnostics tests at primary care level, the APRI score for assessing fibrosis, will enable treatment to initiate at a primary care level. But ultimately, successful implementation will require integration, breaking down of silos of healthcare services, but we must have appropriate allocation of domestic resources to actually implement these guidelines. Thank you very much.
Thank you very much, Wendy, for that thorough overview of the guidelines and how they relate to practice in Africa.